I have a hard job because I have the only, Leslie's talking about gross slides, and that's a technical term referring to what the specimen looks like without a microscope. My slides actually are gross. And I'll give you a warning. I wasn't going to put the actual surgery slides in there, but Melissa told me I had to, so I did. But I'm giving you I'll give you a heads up. So if you are queasy or you don't like seeing what it looks like inside the human body, then you'll have a chance to look away. So, as a surgeon, I'll be speaking about appropriately the role of surgery in treating mesothelioma. Mesothelioma, as we talked about, is extraordinarily rare cancer of the pleura, which is the lining of the chest cavity. And what makes this cancer such a difficult, Dr. Sturman gave the example of gastric cancer, stomach cancer. People think about a cancer, I get this question, it's hard to wrap your head around what this cancer is. People think about cancer as a lump, a golf ball sitting in the middle of something. And when you have, a tumor in the colon or the breast or in the stomach, and it's surrounded by normal tissue, if that cancer has not spread, you can take it out surrounded by normal tissue and you can cure somebody. And that's why surgery still exists with all these different treatment modalities. Mesothelioma is different. It's as though somebody poured the cancer into the chest cavity. There isn't a square inch in that complicated space, which involves all around the ribs, every nook and cranny in the lungs, the diaphragm, your breathing muscle, the pericardium, which is the sac around the heart. There isn't a section of that area which is substantial, maybe a square yard or more, that isn't involved with the cancer. And so it's impossible to actually cure someone from this cancer just with surgery. This is sort of what Dr. Sturman was showing us, but this is what I'm saying. The pleura is this whole surface. This is if you open someone up like a book, this is what you would see. This is the diaphragm. The sac around the heart sits there. The lungs sit inside the chest cavity. And all of these outlined areas, that's the pleura. It's on the surface of the lung over here, and it's on the whole lining of the chest cavity. And when you have mesothelioma, it is a cancer that involves all of those surfaces. The common questions I get about the pleura is, why do we have one? Well, we don't really know for sure. And why do we have a pleural space? I mean, some animals, like an elephant, don't even have a pleural space. So no one is exactly sure. We think it's probably involved with fluid balance in the chest cavity. And every day, several cups of fluid come out of the lungs and get absorbed by the lining of the chest cavity. And that's a dynamic flow, but at any given time, there's only maybe a few teaspoons of fluid in there. When you perturb that balance, and this is the way most patients who have mesothelioma will present, is short of breath. And what happens is that you perturb that balance, the fluid's coming out more than it can be absorbed. You get fluid accumulating in the chest cavity called a pleural effusion. The lung gets squashed and the patient gets short of breath. And so that is probably the most common question: where did that fluid come from, and why does it keep coming back? They took the fluid out. Why is it coming back? And that's why. It's a constant flow. I get asked, can a person live without a pleura? Yes, we know that. And we do not think that having the pleura taken out, and it's done for benign problems. People get collapsed lungs, for instance, and one of the things that sometimes is done is to take out the pleura, and people have measured their breathing capacity. So actually taking out the pleura, we do not think actually affects someone's breathing. And then, as Dr. Sturman went over so eloquently, mesothelioma is a primary cancer of the pleura. So the role of surgery in mesothelioma is, one, it can be an establishing the diagnosis. With Dr. Litsky and Dr. Sturman, often you can get it with a needle, but typically that's not the case in the community. And even here sometimes it can be very difficult to make that diagnosis, and you get the call from Dr. Litsky, we need more tissue, and then I get that call. Palliation of the pleural effusion. So that fluid, if it's accumulating, that's one of the things that a surgeon, or in our case Dr. Sturman, can help with. And then as a means to enable non-surgical treatments, that's one of the roles that I play within our group. And then as the cornerstone, and this is where you take a big leap up in my involvement, as the cornerstone for a multimodal, so all different types of treatments combined, but based around a surgical approach. And Melissa chides me. She doesn't like that I employ a lot of war imagery in this, but that, frankly, is the way I see this. This is the way I see our team. I mean, we're going after this thing. Everyone who's on the stage is really impassioned about what we do. Karen is right. I mean, this is what we do. This is what we care about, and this is kind of at least my image of what we look like. This, unfortunately, is what we actually look like, but this I don't know. So, but that's what we'd like to look like, what we do look like. But we do, as Karen said, we get together. Someone has this problem. We get together on a Wednesday. Everyone goes over. We go over all the cases. We talk about all the potential options. We meet with the patients and present you with those options. So to make the diagnosis, you know, that's the team pathologist decides whether or not we have that. And if we need more tissue, this can typically be accomplished with a 1/2, you know, through a 1/2 to 1 inch incision. And then often, if someone has recurrent fluid, we can deal with that problem at the same time. And there's certain technical points to doing this that are different than some of the other chest surgery that I do. Mesothelioma has a propensity to grow out of incisions. So when we make these incisions, you actually want to think carefully about where you put it. It's always good to put it in line with an area that could be excised with future surgery, or could be incorporated with perhaps radiation. But actually selecting the site of the incision, that little incision, a 1/2 inch incision, is not trivial. You have to work with the pathologist. So when we take these biopsies, and unfortunately, you know, most of the time when we get called for more tissue, it's from someone who, I mean, I went through my 5 years of general surgery training and saw 1 case of mesothelioma. You know, now we see 2 to 3, you know, new patients a week routinely. It's a rare cancer, and the surgeon in the community is trying to do the best they can. You take a biopsy, 99 out of 100 times, you send it to a pathologist, you'll get an answer. That's not the case with this, so we have to keep sending it back. I work closely with the pathologist during the case. I can't ask them, is it mesothelioma? But I do have to ask, do you have what you need to make the diagnosis? Until Dr. Litsky says yes, we can't stop. We have to keep taking biopsies. It involves the surface of the lung. You don't want to mess with the lung when you're doing these things. You can get air leaking out of the lung. It'd be very difficult to treat. And also, talc is sometimes put in the chest cavity to keep that fluid from reaccumulating, and you can have terrible problems if the lung doesn't expand and you put talc in. So there are certain sort of technical things even for these little operations. All right, here's your first warning. If you're squeamish, look away. I'll start you in easy. So this is the incision that we will typically make. You know, it's just about a 1/2 inch incision in this case. And this is the view from the inside. We put in a 5 millimeter, so, you know, about a 1/4 of an inch telescope into the chest cavity, and through that we can get biopsies. This is actually an asbestos plaque. This is the chest wall over here, and that's someone with very early stage cancer, and that's a biopsy that we can take that way. Talked about putting talc in the chest cavity if the lung fully expands. So when someone's asleep, I can ask the anesthesiologist to inflate the lung. If the lung expands all the way and presses up against the lining of the chest cavity, then you do have the option in that setting to put talc in, and it's just sterilized talc, and it causes the lung to stick up, obliterates that space, keep the fluid from reaccumulating. If that doesn't work, or in our case, if during our conference when we met we talked about, and Dr. Sturman says the patient may be a candidate for the gene therapy trial, then we'll put in these pleural catheters, which is a tube that goes into the chest cavity. This part stays out, it's a valve, and then this can get hooked up to this bottle. As an outpatient, you can just drain the fluid, and this has actually been a very good thing for patients with this problem. I'll just show you this thing that we came up with here. We have some patients who have chronic effusions and have actually wanted to be able to swim. That's the one thing you can't do with the pleural catheter. You can shower, you can put a dressing over, but you can't actually go swimming. In some patients, it's a real lifestyle thing. And so what I did was I took one of these pleural catheters, I took a chemotherapy port, and hooked the two together, and then basically implanted that. You can see we're putting it in over here, and then the patients are actually able to go home and access this port and draw the fluid out. So just something that we came up with that can actually be something for patients who are sort of, that would enhance their quality of life. And then the other thing that, as the surgeon, that I do is trying to facilitate or enable other treatments. So when I work with Dr. Simone or Dr. Hahn or Dr. Sengel, and we're talking about doing radiation, oftentimes during surgery, if they want to do something, I can actually put in clips on the tumor specifically, and again, talk about teamwork. We have maybe one of the only departments in the country or in the world where the radiation oncologist will routinely just come to the operating room, take a look at the tumor and say, yeah, you know, if you put that there, we can treat that better. So that's one of the things I'll do, is to make it easier for them. Sometimes, again, more tissue, we need to get special stains and so forth to work for Dr. Alley or Dr. Sturman for the different trials. I can facilitate that. And then also for the gene therapy trial, which you'll be hearing about, my role in this is, again, as a technician, but one of the things that we came up with is same sort of thing. This is actually the device that's used to harvest the saphenous vein for heart surgery. And so when the lung is stuck up to the lining of the chest cavity, it's actually very difficult to get back in there. And so what I came up with was this technique. You can see this thing is in the chest cavity there. That's the light glowing through the skin. That's the view that I get. And we can put this catheter in here, and so patients can get gene therapy even though they have a fused pleural space. So facilitating these other treatments. As I started to say when we're loading the slides, you know, the problem is you can't get a negative margin. This is the analogy that many of you have heard me say. It's like scraping paint. You know, you could spend all day doing it. At the end, there's going to be a microscopic paint chip there, and that's the same sort of problem that we have here, except that this paint chip is a live cancer cell. It's going to multiply and divide. So you have to combine the treatment with other modalities. And again, this is, you know, more war imagery, but you know, this is the way we go after this thing. I mean, that's me, of course, but but this is which also comes with the provision that if we go down, we all go down together. But you know, you have to combine all the different modalities, and so it's only within the context of a team approach that we will even consider surgery. And the goal of surgery is to achieve what we call a macroscopic complete resection, taking out all the disease that we can see or feel. And then we use the other modalities in an attempt to control the microscopic disease that you know is still there. There are two broad approaches to mesothelioma surgery. One involves taking the lung and one involves sparing the lung. So who should have this type of surgery? And this is Raleigh Free. He was the first man to go, that's Bonneville Salt Flats, he was the first man to go over 150 miles an hour on a motorcycle. What happened was he made the first run with his leathers on, he had all the protective gear, and he just missed it. So he went back, and before the officials could see, he took off all of his leathers, put on a Speedo and a pair of sneakers, and instead of sitting on the seat, laid down so he could be more aerodynamic, and actually set the world speed record at the time. Is it crazy? Yes. Did he accomplish something? You know, he did. Was it worth it? It was to him, but it's not for everyone. And this is a similar sort of thing. I mean, I look around this audience and I see the patients who have gone through this, and I see the families of patients who have gone through this who sadly are not here. You know, that's why we're here. These are the most courageous people I've ever met in my life. And, you know, me, you know, I admire Raleigh Free, and, you know, and I admire the patients who go through this. But surgery is investigational for mesothelioma. It's not for everyone. It takes, you know, a level of courage and daring to do this. The lung sacrificing surgery is called an extrapleural pneumonectomy, and that operation, basically, you're looking at this cartoon here. They've taken it off. That's the diaphragm, and that's the pericardium, and the whole lung is encased in the tumor, and it comes out. And then this cartoon shows basically the concept of lung sparing, where you go in and, you know, you incise the tumor and you basically peel the cancer out and leave the lung behind. Now, these pictures are serious, so if you are queasy, this is the time not to look. This is an extrapleural pneumonectomy specimen. So this is what it looks like. You know, this is the cancer. This is the lung in here. You can see this cancer all around the surface, going through the 2 lobes, that's right here. And the diaphragm is down here. The pericardium is on the far side, but basically I've taken out the whole lung with the lining of the chest cavity, the diaphragm, and the pericardium. This is the lung-sparing surgery, which is currently what we do. In our hands, with the combination of treatments that we do, this seems to be producing the best results. And as Dr. Sturman pointed out, there's a big difference between having a lung and not having a lung. And this is currently the approach that we take on all patients. And in this case, what you're looking at, here's the cancer. This is the chest wall in here, and we incise the cancer. You can see how thick this is. And then, so this is cancer here, and this is the lung that we're separating from the cancer. And when you do that, it can be technically challenging. And a lot of surgeons, and we just came back from the meeting to which Leslie referred the International Mesothelioma Interest Group meeting, and it's a pretty small club of guys that are doing this at this point. And this is the reason when it goes down between the fissure here, it can go all the way down to the pulmonary artery. So you're looking into the chest cavity. This is the middle lobe of the lung, the upper lobe, the middle lobe of the lung, the upper lobe of the lung, and the lower lobe of the lung. And this is the artery, the arterial supply to all that, and the cancer was right on that. So you really have to skeletonize that. If you want to get a macroscopic complete resection, no cancer you can see or feel, that's what you have to accomplish. And that can be technically challenging. It's easier for me and takes less time to take out the lung than to save it. But at this point, with what we're doing, it does appear to be worth it. And these are the specimens that come out. And these things can range, we measure the volume of these things from, 200 to 300 cc's, so, like a cup of coffee amount of cancer, all the way up to, more than 2 liters of cancer. I mean, these can be really voluminous tumors. So, in summary, surgery can be used to establish a diagnosis. It can be used to palliate a pleural effusion. It can be used to permit other treatments, which include radiation, chemotherapy, immunotherapy, or it can serve as the cornerstone of a surgery-based multimodal treatment. And again, I can't stress enough, I never make the decision to operate in isolation. The whole group has to decide that this is going to be a good thing for the patient to even offer it. So, we always make this decision as a team, and, we always attack it as a team. And that's what you get when we're taking care of you, everyone's coming along with that. And then, again, as Dr. Sturman pointed out, the proudest part of my career is being part of this program. And, these are the people that really make this happen. So I thank you.